All right. Good afternoon, everyone, and welcome. So, we are thrilled to have you with us today for this special session hosted in partnership with our trusted billing partner, Practice Solutions. So today's presenter is Jeremy Zug. He's going to share his expertise on one of the most important and sometimes challenging aspects of running a mental health practice. And that's, navigating those insurance companies, avoiding denials, and guidance around building a smarter and more efficient billing cycle. So for those of you who may not be familiar, Practice Solutions is dedicated to empowering the delivery of mental health services through compliant, accurate, and transparent revenue cycle management. So as our billing partner, they collaborate closely with providers, ensuring that billing processes are not only efficient, but also sustainable, ethical, and supportive of that quality client care. Yeah, so I'm going to just pop over to our housekeeping real quick. So before we get started, just a reminder, everyone is muted. Whoops, not questions yet. There you go. Everyone is muted. Your cameras are enabled, so we always love to see your smiling faces. So if you would like to turn that on, say hello. We will have a Q&A session after the presentation, and then there'll also be a recording of the webinar as well. All right. So without further ado, Jeremy, would you like to take it away?
Yeah, I'll take it away. Thank you so much, Katie. And I'm going to share my presentation with all of you. I really appreciate all of you being here to talk about one of my favorite topics, which is billing. And so we're going to dive right in. So if you can't see this, feel free to chime in and we'll figure it out. So I'm Jeremy Zug. I'm one of the co-founders and partners here at Practice Solutions. My wife is the other partner, but we have a little under 40 full-time billers across the country that specialize in billing and billing issues. So quick overview here. We're going to do some myth busting. We're going to talk about key players, revenue cycle management, common billing challenges, and then, like Katie said, we'll talk about the Q&A. So it'll be exciting. So myth busting, claim submission is the touch of a button, right? Oftentimes billing is often said that it's claim submission or just I click a button and my billing is done. And that's not exactly correct, right? I mean, once a claim is submitted, where do they go? How do you know what to put on a claim? What happens if a claim gets rejected? In Michigan, there's currently this issue with Blue Cross Complete. How do you troubleshoot claim issues with a payer, right? What happens if a claim is denied? And who feels the impact when billing goes wrong? These are all myths that we're going to work through today and hopefully dispel. But first, let's talk about the key players in insurance billing, because we like to think about insurance billing as a game, right? And games are not too terribly hard to figure out once you have the right orientation. And once you have the right orientation, you can really win at this game that we're playing. So key players in the insurance billing world. First, the insurance company. They contract with you and the patient to negotiate rates for healthcare services. There's the clearinghouse, which Checkpoint wants you to forget the word clearinghouse, which is amazing. They review claim information for accuracy. You have your EHR, right? You have to have, well, you don't have to, but the world is increasingly more digital. EHRs allow you to get paid and manage your practice in a way that in the community mental health days were, it was unheard of for sure. There's the provider, you, the clinician, and your patients. So these are the critical players in the life of your practice and in the life of billing. Here are some optional players in billing, but optimal if you can find them. The first is a credentialer, right? Somebody who facilitates the process of becoming in network with an insurance company. A biller, someone who streamlines the billing process to make sure that all your information and patient information and session information is recorded and submitted properly, and deals with any insurance shenanigans. I know everybody that we work with worries about clawbacks and audits and any number of actions the insurance companies can take. And so your biller is supposed to have a level of depth that they can handle that stuff for you so that you can continue to run your practice. And then an admin. someone who aids in the collection and organization of patient information. So let's talk about revenue cycle management now that we have the key players and the optimal players on the board. And this process, revenue cycle management, if you were to Google this process, you'll notice that our revenue cycle management process and whatever comes up on Google is a little different. And it's like a 6 millimeter difference, but it makes a huge difference. And I'll talk through why. Revenue cycle management starts with credentialing. That process needs to be as detailed, as thorough, and as organized as you can possibly get it. Fast forward 6 months, you can now take a patient comes in, you collect all of their information called patient registration. Now you're into the cycle, right? Eligibility and benefit checks. Are they eligible for services with the codes that you're going to bill? What are the benefits? Do they have a deductible? Do they have a copay? Do they have an out-of-pocket maximum? And what are the accumulations toward all those totals? Those are the first 3 steps. At Practice Solutions, we then advocate that practices go from E&B not to claim submission, but to payment posting. And here's why. At payment posting, you're going to get a large check from the insurance company. It's going to have a lot of sessions on it. It's going to have reasons for payment, but more importantly, it'll have reasons for denials. This is where you capture that denial information and can actually do something with it in aging follow-up, which is our next step. There you can contact the insurance company, you can file appeals, you can argue with a rep on the phone. Then you get to claim submission. Oftentimes what we see in practices that we work with, they come in, their revenue cycle management process goes from E&B to claim submission, and then claim submission and claim submission and claim submission. And what you get there is this really nasty cycle of denial in, and the top denial reason in the country for any specialty in healthcare is duplicate claim or service, which just means that you resubmitted that claim 10 times, and now you have 10 denials, and you have to get to the original denial, versus taking a moment, doing your E&B check, and then going to payment posting, collecting all the denial and rejection information, dealing with that, and then submitting a clean claim. This process, how we've prescribed it here, makes your billing way more efficient. Again, it's a small 6 millimeter shift that makes all the difference in speed of payment. All right. Now we're going to talk about administrative domains really quick. So credentialing, which is the prequel to billing. So with each insurance company, you need to know the following. Now you need to know a lot, but these are basic credentialing items you need to know. NPI, tax ID, and then your practice information. Then we get to patient registration. And without this, effective billing is dramatically reduced. Credentialing is important, especially since if you are newly minted as a credentialed and network provider, and then you start submitting claims and you start to get the dreaded NPI not registered denial, that's one where you take a beat, you make sure you're credentialed properly, call the insurance company, confirm your contract, and then you can move forward. Patient registration, though, if you don't have a really consolidated patient registration process that is smooth, you can actually influence patient outcomes positively or negatively depending on your patient registration process, right? So all of the information here on the slide is information you need to know, and it needs to be really accurate, right? If you translate a couple numbers, get a date of birth wrong, you're going to get a denial. So you need to put on the most detail-oriented hat, or have the most detail-oriented person in your practice doing this process. So those are the administrative domains. Here are the billing domains. Eligibility and benefits. Is the patient eligible? What are their benefits, right? E&B checks, though, are not a guarantee of payment, and they're not even guaranteed to be accurate. Anybody who's done one knows that the rep or the automated recording gives you this really vague back door for the insurance company that says, this is a quote, it's not a guarantee, you can't hold us liable for the information provided. And based on our script and the result of claims that we see, those are wrong between 10 and 20% of the time, which is really interesting that it's wrong. But if you don't do it, then you really don't know where the claim should go, and you don't have a good idea of even the ballpark, right, of what your patient is going to owe. This is how we help patients understand insurance, because oftentimes one of the barriers to patient registration or eligibility and benefits is that patients themselves don't understand how insurance works. So the way that insurance works is there are 3 stages related to responsible party for payment. The first is getting a deductible paid down. Now, for some plans across the country, and especially for Medicaid clients you don't charge, right? You can't charge them. But for somebody with a commercial insurance plan, usually there's a deductible, and the patient is responsible for 100% of your contracted rate, your allowable amount, and the insurance company is responsible for 0% unless the deductible does not apply. Once they meet their deductible, though, they move to the cost sharing stage, stage 2, where they either have a copay, a flat dollar, clean dollar amount, 20 bucks, 25 bucks, or a co-insurance. It's a percentage, so there's a little bit of arithmetic involved, but it's usually kind of a what we refer to as a dirtier number, like $24.39 or something like that. And then the insurance company pays the balance of your contracted rate to make up your full allowed amount. The third stage, which we're at the time of this recording, we're starting to head into when most patients are starting to enter stage 3. And that's where they meet the entire out-of-pocket maximum on their plan. The patient owes 0% and the insurance company covers 100%. Usually we start to see these get covered from August until the end of the year. It's very rare that you see an out-of-pocket maximum met early in the year because it means something not fun has happened. So that's a good way, that's a good mental model to stratify how your patient's insurance works. Next is payment posting, right? You're going to record payments and identify issues that result in non-payment. Payments need to be posted before doing any aging activity because you want to note any denials. You want to close claims that have been paid. You want to verify paid amounts against your fee schedule. That's particularly important. I'll tell you a story really quick. We were contracted to do some consulting work with a very large mental health organization in Wisconsin. And through one of our audits, we found that a particular payer, it would not come as a surprise to any of you which one, was underpaying each of their claims by about $1.20. So, which doesn't sound like a lot, except when you do the kind of volume that this organization was doing, it really added up. So we tried to go around through the normal channels of that company to identify and communicate that they'd been underpaying. Eventually, we had to rope in an insurance commissioner. Long story short, we ended up getting that company $500,000 of payment for the last 3 years because they were underpaying and nobody was checking the paid amount relative to the fee schedule. So that's really important, right? And like I said, I know $1.20 doesn't sound like a lot, but over years and years of work, it really adds up. So, and then you need to verify that patient amounts have been collected according to how the claim process, and then record your denials. I mean, that's really, really important. And then you get to aging follow-up. That's where you follow up on rejected and denied claims. Patient balances can be collected. Hopefully you're doing that at checkout, but if not, you can do that here. And you can resolve any open claims. And then finally, we get to claim submission. And that's where you summarize a patient appointment to report to the insurance company for reimbursement. Claim submission should be done after payment posting and aging follow-up so that no duplicate claims are submitted. My hope for your practice is that you don't get a single duplicate claim denial. You catch those really early. You drill down to the foundation of the claim issue and solve it the first time instead of resubmitting claims a bunch. Claims should include your credentialing information, provider and practice, patient information, and appointment information. All a claim does, and this has been debated for a long time, and this is actually pretty controversial, but all a claim does is get to payment. It doesn't communicate anything that doesn't get to payment. So if any information is wrong or incorrect, you will not get payment. So let's talk about the path to a clean claim. First, you get an appointment and then a progress note. You submit the claim, the clearinghouse does its QC, and then it goes to the payer, and then payment is remitted. That is the flow of how a claim gets from your office to the insurance company to your bank account. Any barrier in any of those processes is going to result in non-payment. Like you get the address wrong, the date of birth wrong, your credentialing information doesn't match, the client has a carve out. There's 100 reasons why a claim wouldn't result in payment. But the cleaner your internal processes are, or the cleaner your biller's processes are, the more you can scale a relationship with an insurance company for the benefit of your practice. All right, I want to talk about some billing tools because often we get asked a lot about like, what's the tech stack I should use? And all of you know with the rise of AI that there are a zillion tools to use now. So billing tools, EHR, EMR, and practice solutions, when we get asked by electronic health record systems if we'll adopt their EHR, we have a very specific list of questions that we ask, and it's a very thorough process that our team runs an electronic health record through. But you need to look for things like clear rejection reports, clear aging reports, patient aging reports, revenue reports. Reporting is very important, but also, is there a place to store eligibility and benefit information? What's the costing for an EHR? Does it flex with you? Is there a payment processor? And outside of those things for an EHR, we look for, does a practice have a CRM? Are they managing their intakes really well? Because again, you got to keep in mind, the color dye that you pour at the headwaters of patient registration is the same color that you get at payment. So if you're messy up front, you're messy at the back end. And then an accounting software, please get an accounting software. Doing accounting out of your electronic health record system can be quite messy and complicated, and you'll come up with different numbers, and it can be very frustrating for you, the practice owner. So we highly recommend an accounting software. And then a clearinghouse, which with Checkpoint, that is built in. Shouldn't have to worry about that. But finally, if you're credentialed with insurance companies, please set up portals. It's really the best way to communicate with insurance companies. You get really quick answers that way. You get updates on what they're doing. It is very good to have those, and your biller will likely ask for them. Common billing challenges. A claim has been reviewed by the insurance company and denied for payment. Top 3 reasons: duplicate claim or service. So don't resubmit a claim without resolving the denial first. Coordination of benefits. Let's talk about coordination of benefits. It's the #1 reason for clawbacks in our country in terms of a billing. So if an insurance company is going to clawback money, coordination of benefits is likely the reason, which means that your client had a different insurance that should have been primary for that benefit period. So ask your clients, do you have another insurance company that you're aware of? Because if they do, you need to submit to that one if it's primary. If it's not primary, then you should submit to that insurance company for the secondary, but we see that a lot. And at the top of the year, your clients are going to get an unmarked envelope that they'll likely throw away. I have thrown away mine before, admittedly. I know that's kind of embarrassing for the billing guy to say that, but it's really easy to throw that guy away. That's like a coordination of benefits form. You got to fill that out. Otherwise, claims get denied. And then lastly, this one really bothers providers, and it ought to, but denied for medical necessity. So you bill a service, it gets denied for medical necessity, and then you have to talk to a provider at the insurance company to prove that your service was valid. But oftentimes you're talking to a provider at the insurance company that is not in your specialty. It's hard to explain to a dermatologist why a therapy session was necessary. So those are the top 3 reasons. And then obviously demographic information. Rejections. This means that the claim has actually not reached the insurance company. It went to the clearinghouse, and the clearinghouse kicked it back for your review. So most often, NPI not approved as an electronic submitter. So this is a credentialing issue. It means that the insurance company does not have your NPI listed in their system to submit claims to them. So you can either set up EDI interactions, there might be an issue there, or there's a credentialing issue. Patient demographics, dates of birth, addresses, names, that happens all the time. And then modifiers that are inconsistent with the place of service billed. So that's also pretty common. If you read the provider manuals, or your biller should know that, which modifier to use, we highly recommend knowing your modifiers. Coding. So coding now, especially with a system like Checkpoint, is pretty automatic. So you can have your CPT codes, your modifiers, place of service codes, and diagnosis codes preloaded, and then you can select the correct one. And in mental health, for all of you here, it's pretty simple. If you are in a medical specialty, it's a little bit more complicated, but most of the time we all know what the coding should be. Timely filing is a common claim issue. It means that the claim has not been submitted within the contractually agreed upon window of time after the appointment. Here's a little fact for you that I learned from my friend Kathy Gilbert, who ran Magellan's provider network for a very long time. She said timely filing is one of the easiest terms in your contract to negotiate. So ask for more time, right? If it's 30 to 60 days, ask for more time. And then you can get that adjusted. Otherwise, claims need to go out every Monday, twice a week, 3 times a week, however often you need to not go past timely filing. Credentialing errors are tough. It's a common issue. But credentialing is not complete until you have a welcome letter and an effective date. So please don't submit claims prior to that date. Know how you're credentialed and be really thorough, which I know can be tough. So if you don't want to be the thorough person, find somebody who's really good at it. And then finally, time. Billing takes a lot of time, unfortunately. And many providers try to do it all and find themselves falling short. And if you're a provider doing your own billing, I can promise you that you are the highest paid biller in the country. Decide where your time is most valuable, outsource or insource your billing, and then stay consistent. So we'll get to the Q&A, but I just wanted to offer this to all of you that we have an exclusive rate increase request form. We also have a survey here to find out if there's a service at Practice Solutions that's right for you. We just announced our learning platform, the Hourglass. So that has all of our tools and downloads and KPI dashboards and any tool you'd want for your billing department there. So you can subscribe there. But yeah, we wanted to offer that to all of you here, which I'm sure we can get afterward. But let's jump to the Q&A. Yeah.
All right, awesome. Thank you. Just a reminder, if you guys do have questions, be sure to post them in the Q&A section. There should be little Q&A chat bubbles at the top. If you post your question there, it'll pop up on my end. If you can't find that or you can only find the chat, feel free to use that as well. Just be careful to kind of post one thing at a time in there because it can get a little crazy. But either one of those areas will work just fine. All right, so let's see. Let's get to how does a practice owner typically decide when it makes sense to outsource their billing?
Oh, that's a good question. So, like, what are the markers that a practice would use to insource or outsource?
Mm-hmm. Outsource.
Yeah, that's a good. Oh, outsource. So
Yeah.
here's my general answer here. A lot of clinicians go through a typical life cycle with this, which is they try to do it themselves and they want to understand how it works. Totally get that. I don't know tax law. I know kind of how it works, but I know enough to know if my accountant is doing a good job. So I totally get wanting to know how billing works. But once it starts to creep up on like 1 to 2 hours a week of work, and I know that seems like a low threshold, but that's kind of the time to outsource because you want to be really comfortable with your biller. You want to know how they operate. You want to understand the relationship that you're in. You want to be confident that they know your state. They know your payers. They know your EHR. And that gives them plenty of time to onboard and get things rolling. And then you convert those hours to whatever you want. You convert those hours to growing your practice, seeing more clients, spending more time with family, or what have you. That will expand until you hit however many providers you grow to. And then it becomes a much more exciting, dynamic conversation. But your biller should be able to flex with you. They should be able to provide service frequency at a level that you're satisfied with, and you should be able to see what they're doing. And this is a common theme that has recently, Katie, bubbled up recently that really kind of gets my goat in some sense. I think that's the right phrase, but this idea that your biller can do billing in the background with their own tech stack that's a crazy idea. Don't do that, right? Your biller should be able to do everything they need to do in your electronic health record in Checkpoint, and you should be able to watch it all happen. And then if you don't see it happening, you can throw up a flag. But all too often with that other model I was talking about, you lose a ton of money. So that's a longer answer to what you asked. But as soon as billing is taking up considerable, measurable amounts of time on your calendar, time to get rid of it.
Mm-hmm. Okay, great. Awesome advice. Let's see. With the rise of AI, what billing and RCM innovations are you seeing on the horizon?
Yeah, a bunch of them have popped up. I have a few concerns. Basically there are a bunch of like auto posters, which that technology has been around for a very long time, that auto posting feature. My only concern with that is you need to be able to check for a secondary claim and you need to be able to identify denials, and that AI hasn't gotten really good at identifying either of those two things yet. So you want to make sure that you're watching that. The one I'm really excited about is auto calling the insurance companies to follow up on claims. And then it's really interesting. In certain states, you're
Wow.
not payers aren't allowed to use AI to process claims, but there's no legislation that I'm aware of that prohibits a practice from using AI like that to contact the insurance company. So any of those auto calling features that follow up on claims, I'm a big fan of, as long as they keep your PHI secure, which is always like a big topic. But
Mhm.
that could save you a considerable amount of time. So that gets me pretty excited.
Wow, that's awesome. I can't imagine not having to call the insurance company, just having someone else do
Yeah,
it.
yeah. And I'm really curious to see what payers are doing for prior authorization. I know following AHIP, which
Mm,
is the big insurance company conference, a lot of them committed to renovating the prior authorization process. It's been a point of contention for like a long time. And so I hope that AI can somehow solve for that particular process.
Awesome. Let's see. How do you resubmit a claim that's been updated with new information without it showing as rebuild, or the payer gets the claim as a replacement claim? I would like the claim to be a fresh claim and not referencing the prior claim number. I don't know if that's a checkpoint question slash.
Might
Um,
be, yeah.
yeah,
There's
maybe.
so is the question about like a corrected claim? Is that the question?
Yeah, it sounds like it. It sounds like they're wanting to submit a claim as like an original claim versus like a replacement claim or a corrected claim. And I can answer that from like a checkpoint side. I'll reply to them. But maybe if you want to talk about like the differences between those things, because I think a lot of insurance companies will say, resubmitted, or you hear resubmit, corrected, replace, void. Like when is it appropriate to use those different things?
Yeah, that's a really good question. Each pair is a little different, but generally the process for a corrected, voided claim is that you use the original claim number, which is another reason why, and I'll go back to that a slide for our revenue cycle management process. That's exactly why we start a payment posting. Because if you're 10 denials deep on a claim and then you need to submit an original claim, which an original claim the insurance company reads as there are no prior submissions, so aids the idea is that it aids in the like getting out of the denial cycle there. Most payers like the original claim number on the claim, but if you use a claim number that from a claim that denied for duplicate processing, you're going to get another denial. It's very frustrating. So you need that original submitted claims claim number to submit a corrected claim for that denial. So that would be how you submit a corrected or voided claim. Sometimes payers still like them in paper, which is wild to think about. You have to
Mhm.
put like void the original claim number at the top of the claim form and then mail it in, or you fax it, which is again wild to me. But that's how you do a voided or corrected claim. And then an original claim, usually the payer will see your claim submission and then work some magic on their part to make that an original claim. And then I'm sure Checkpoint has ways to indicate which is which.
Mhm. Yeah,
That's
awesome.
a good
Yeah.
question.
One thing too to kind of be careful of is if you have multiple line items on that one claim, right? When you're doing like replacements and corrections, you want to be like really careful that you're replacing everything
Yeah,
and not
yeah,
just
that's
the
right.
one, right? Yeah. I've done that myself
Yeah,
before I knew what that was. Yeah.
yeah. It's super easy to miss. I mean, those are the kinds of details that are really easy to overlook and cause a lot of
Mm-hmm.
consternation. Yeah.
Mm-hmm.
I think is there a question about the system here set up to auto route primary claims? I think it's in the chat box. Is that okay?
Yeah. Yeah. I'm bouncing around between a couple. Yeah, is the system set up to auto route primary claims to the secondary, and how will this work if there are a few non-contracted payers? Yeah, so as far as Checkpoint, it does, if you have the primary and the secondary listed, it'll send to the primary, and when that EOB comes back from the primary, it'll generate a secondary claim, and all that claim information will go out the door to the payer. It does get a little tricky if you're not contracted with some payers as far as doing it electronically, because typically if you're not, contracted with them, then you can't submit electronically. So then it kind of gets into some manual processes. But we do have, other options if that's the case. There's still a way to do a secondary claim. Um, do you want to talk a little bit just like best practices when it comes to like primary and secondary claims and maybe.
Yeah, so there are two things to know about primary and secondary. The standard process for a primary and secondary usually follows the birthday rule, unless, and I'll talk about the birthday rule in a minute, but if a patient has to call out, especially for a minor, which insurance company is primary versus secondary. If your patient doesn't call out which one is primary and secondary, the insurance company will follow the birthday rule. And the birthday rule says whichever guardian or parent or spouse, whichever's birthday comes first in a calendar year, that's the primary. And then whoever comes later in a calendar year, that's the secondary, regardless of the year they were born. Just in a calendar year, if their birthday was, if one is March 1st, that's the primary. And then if the others is April 1st, that's the secondary. So that's the birthday rule. Insurance companies will assume the birthday rule unless otherwise specified. So ensuring that your clients understand that and keep that straight. That's a good way to think through secondary. And then tertiary payers are a reality in the system. So tertiary payers are something you have to ask about now and consider,
Mhm,
especially with added plans and supplemental coverage and all
mhm,
kinds of stuff. So making sure that you ask about the entire breadth of somebody's insurance coverage.
mhm. Yep. Now, does that birthday rule also apply to like Medicaid, Medicare? Are there special things around those two insurances where maybe one would always be the payer of last resort?
Medicaid is always the payer of last resort, and then Medicare is primary. Yeah.
Yeah.
And then if a client has a commercial insurance and a government a government payer, the government is always the payer of last resort to a commercial insurance plan.
Let's see. With a lot of upcoming legislation impacting Medicaid access, what are your recommendations to providers that are largely Medicaid based, in preparation for these changes?
Sorry. So the question is about the legislative changes that are coming with Medicaid. Yeah, we don't really know yet. A lot of those changes are going into effect at the end of next year. And the estimates for the amount of people losing coverage vary. So the Congressional Budget Office says 10.1 million people will lose coverage. And then the upper limit of what I've seen around people losing coverage is 30 million. So we don't know what the impact will be. I'm sure there will be glitches in Medicaid portals around work requirements. You can count on it. And so here's what I would recommend. If you are a primarily Medicaid-based practice, start to think through how you're diversifying your revenue, because likely when these changes go into effect, you're going to experience some bumps from Medicaid. And I know that's tough, right? I initially got started in this industry when I was 14. The local community mental health center in Montana posted a job in my high school for someone to make paper charts. Okay, so like no EHRs, we're like making paper charts. I'm sure some of you remember those days. And the clinic was mostly Medicaid funded. And one of the reasons why they struggled was they didn't diversify their revenue streams very well. And so now is the time to do that. You have plenty of time to credential with a commercial payer or to start to build a private pay caseload to handle the bumps that are likely coming. That's my first comment. My second comment is that administrations are like a substitute teacher, so it's temporary. This one is just assigning a little bit more homework for Medicaid providers. And then all you have to do is wait, because the next administration could change it either way. So making sure that you know the moves on the board that are available to you as a practice allows you to manage gracefully the vicissitudes of legislative changes.
Awesome. Is there a point where the agency should fully insource billing or set up a hybrid of partial in-house and outsource with a biller?
Yeah, it's a good question. Our advice is that once you approach around 1.5 million in top line revenue, it's time to think about going hybrid or in-house. A couple reasons for that. One, your outsourced biller is likely getting pretty expensive, and you can cut costs. That's always a smart business move, by the way. If you can cut costs somewhere for a better, less expensive option, you should. And that's a really easy metric to follow. 1.5 million, according to the thousands of practices that we work with, that it tends to be the threshold that a biller that's in-house with taxes, benefits, salary makes the most sense. Or a hybrid model makes a lot of sense if you want to retain an office for a therapist to use. So oftentimes space is a consideration that if I hire a biller in-house, they got to sit over there in office B, but office B could be used for therapy, which is revenue generating. So those are some of the considerations that we would use. And then a hybrid model, which our billers work with all the time, which is somebody's in-house doing operations, communicating with their personal biller on our side of things, and then they run with the program from there. That tends to work pretty effectively. But good business sense would be hire internally at a certain size. You get higher touches, you can talk to them. At that size too, therapists are probably like, hey, what's going on with this claim? What's going on with that claim? And it's a lot easier and better for the owner to just say, go to office B for those questions. So yeah, a lot of pros and cons there, but our general advice is 1.5 million in top line revenue.
What are some key things to look for when evaluating a biller to hire?
This is a good question. We get asked this a lot. Do they know your electronic health record? That's the first one, right? They need to be an expert in your electronic health record. It's not enough to just say, hey, we've done, like, if I have dust in my hand, I just go like poof, like that. Like I have experience, but is it good experience? Is it the right experience? Is it the experience that helps my practice do this stuff better? So do they have experience and knowledge and desire to work in your electronic health record? That's first. Second, what happens, like what's the plan, the succession plan if this individual maybe goes on vacation? Is your billing going to get done? What if they turn over? Is there a backup plan? What if they want to have a child in the next year? We hire a lot of females, and that happens. So one of the benefits of having an outsourced biller is that stuff's covered. You don't deal with turnover. Your billing gets done every single week, and you don't ever have to deal with turnover or shenanigans. But you need to make sure that there's a plan. Then you need to look at the contract, make sure you don't agree to things you don't agree to, if that makes sense. So make sure that you understand the length of the contract and what's expected, and what does the termination process look like? What does payment look like? Are you charging me for everything, or are you just charging me for the allowed amount? Well, how does patient collections work? So you got to work through some of those processes before you select one. You can't just go like, subscribe and then you're with a biller. There's a little bit of an onboarding there.
Mm-hmm. Awesome. how hands-off do agencies get to be with billing once they've onboarded a biller? Like, what type of collaboration is usually needed between those two parties?
Yeah, delegated does not mean abdicated. So what we mean by that is just because your biller is doing your billing doesn't mean you're not involved. So the kind of client that we love working with is a practice owner who wants regular check-in, but trust that it's getting done and that we can both track the results. So you and I, Katie, sit down and we say, all right, how's the revenue looking? How's the aging looking? Are we seeing tangible results? And if not, what do we need to do to change that? And then we make changes on our side and we move things forward. So there is check-in, there's communication, but the keystrokes are not in your office. The calling is not in your office. The turnover is not in your office. The HR expense is not in your office. There's a lot of things that get taken off your plate, but there's still like you got to have a pulse check every once in a while to make sure things are moving forward.
Mhm. What in your experience, what are some of the most common like billing pitfalls for those small to mid-sized practices? And what can they kind of do to mitigate those?
Yeah, I'm moving too fast. So we got to get credentialed. I left my group practice. Leave plenty of time. If you're going to work with insurance, leave plenty of time to get credentialed. Also, have a plan for which insurance companies you're going to take. Here's a big one that we see. And we just saw this with a practice we started working with recently that had 30 patients and 30 payers. It's like, that's not a great strategy. And I'll tell you why, because the spaghetti at the wall thing just doesn't make sense. But you didn't get into this work because of the money. You didn't get into this work because it was easy. You did it because you care. And so there are some payers that have populations of people that you care deeply about, and it's a non-starter for you not to work with those folks. Totally get it. That makes sense. Sometimes those payers, though, don't keep the lights on. So you have to have pretty sophisticated math and thought around if I'm going to take payer A, because that's the mission of my practice, I have to do payer B and cash pay to make all that make sense. So having a strategy around payer selection for us is extremely important. Whenever we hear of a practice owner that goes, hey, I I had this high paying payer, but they denied 30% of my claims. So I kicked them to the curb so that I could do more volume with this payer over here. We love to hear that. That's like music to our ears because that means that practice owner is in touch with their long-term vision and long-term goals in mind. So always have the long-term in mind when you're working with insurance companies. Leave yourself plenty of time and be as detailed oriented as you can.
Awesome. Thank you. I feel like you were just a wealth of knowledge, Jeremy.
Oh,
I
thank
love
you.
it. Yeah. Um, do you want to tell us a little bit more like about what Practice Solutions does and how it can help some of our providers?
Yeah, we have three primary service offerings and then a fourth that is free. So our mission statement, like Katie said, is that we exist to relieve you of the burden of billing and educating around best revenue cycle management practices so that you can focus on patient care. So we educate for free everywhere. You can listen to our podcast, you can buy a copy of the book and learn about billing, you can go to our blog, all that is available. But our three primary ways that you can interact with us in a higher touch way. The Hourglass Learning Hub, which we just took all of the tools that we use every day from credentialing, like all of these domains of billing you see here on this slide. We have all of our downloads, all of our curriculum, all of that available. You can subscribe to that today on our website. And you can implement our systems in your practice on a DIY basis, or you can have your biller do it if you're a larger group. So that's a low touch way to work with us. The second, let me back up really quick. And the Hourglass too has Ask the Biller. So if you have a biller or you are the biller and you have a question or a situation you need help with, you can submit a question through there and then we'll provide an answer back to you. So you have ongoing support. And then the thing that I will, nobody's around, so I can tell you all about it. But the item on our roadmap we're really excited about is the ability to look up rates around you in your area by NPI. So hopefully that rolls out here in the next couple months. that you can access, and that we're really excited about that. The other way to work with us is done for you billing. So in keeping with the medical language, we internally call it DFib, so done for you billing, where we basically take our systems and tools, we'll do the billing for you. You convert that time to growing your practice, and that is extremely effective. DFib, done for you billing, usually we see growth rates around 15 to 20% year over year for practices. Which then leads to our highest touch service, professional services, where we do a practice health check, which is an audit, not a scary one, I promise. You get a really comprehensive report around optimizing your billing. We can either do it for you or you do it yourself. But that's the highest touch way to work with us is practice health check, professional services. But those are like the 3 levels to work with us.
Right, awesome, great. Yeah, and I always like to end kind of like on a warm, fuzzy note. So do you maybe have like a recent success story that like you could share with us?
Yeah, I have a really good one. So there's a practice in Michigan that we were a really big group practice that we had gotten in touch with through personal connections, and they're a Medicaid only practice, which is just blows my mind at the level of commitment that practice owner had sunk there, because she knew what she was doing. She knew she was going to deal with shenanigans, but then grew to this 40, 50 provider behemoth. And they came to us with over $1 million in aging. And we knew, and part of the conversation was, we want to clean up the billing and then hand it off internally, because we know this is going to, like, we're going to be more expensive than you want to pay. But we also know we got to get payment. So they came to us with $1 million in aging. The providers were really upset. And then we just finished up our year with them. They went in-house. She saved a ton of money and resource to continue to do what she's doing. But we got the aging from $1 million to $100,000. And at that same period, their revenue tripled every month. So it was really, really fun. It was a great practice for us to work with. But we went in, we had good expectations on the front end. We had really great results. We had a wonderful, I think we had 4 or 5 billers on that account. And they just ran away with the billing. It was really exciting. So, and it was also really encouraging to help them go in-house, because we know it just furthers their mission. So we were really pumped about that. Thanks for asking.
Okay, awesome, great. Yeah, that sounds amazing. Yeah. So how can if a provider is maybe interested in like your services or knowing more, where can they reach out? I think you had QR code on one of
I
those
do have a
slides.
QR code.
Yeah.
Yeah, it's right there. The QR code. So if you scan that QR code, it takes you to a little quiz about which service is right for you. Or if you just go to the contact us page at our website, which is practicesol.com, reach out to us, have some questions there, and we'd love to get you paired up with a personal biller or billing team for your practice.
Awesome. Alrighty. Well, thank you so much. And thank you everyone for joining us today. It was definitely a very informative session. Yeah, and I'm sure we'll have more of these in the future. So we look forward to you joining us again, Jeremy.
Yeah, thanks, Katie. Thanks to Checkpoint team, and thank you to all of you listening.
All right. Have a good day, everyone. Bye-bye.